Okay. The next set of discussions is going to be on anticholinergic drugs. The flower that you're seeing right here is called the nightshade. It's what actually was used a lot of times in Europe to poison people. It actually has scopolamine in it and high concentrations of atropine. Okay, so it actually was used as a poison before. It was also used therapeutically in the old days to treat seasickness. What they would actually do is they would take the flowers and crush them, and then they would put it as a pellet and would put it behind the ear. Geez, doesn't that sound familiar? Okay, it's just like scopolamine that we use nowadays. So they knew about it 400 or 500 years ago. So things that you think that are new are really not. What you're just seeing is the application of old knowledge in very refined medications. But many stuff that we actually use comes from plant material. And I think that's part of teaching pharmacology is a little bit of botany. What are anticholinergic drugs? Let me see. The key points are the following, which is structure-activity relationships, mechanisms of action. We can go into pharmacokinetics, clinical use. I'm going to talk about the central anticholinergic syndrome, which is, I think, not taught enough because you do see a lot of it. At least in Naples you do because you have the older population. How do you deal with overdose? And then also the effects on decreased barrier pressure. Anticholinergic drugs basically are a competitive antagonist for acetylcholine at the muscarinic cholinergic receptors found in the heart, salivary glands, smooth muscle of the GI and genitourinary tract. And some of these agents will actually cross the blood-brain barrier, which are the tertiary agents. The tertiary agents, which is on the top, is atropine. The middle one is scopolamine. If you look at the nitrogen group, it does not have a charge group on it. Okay? If you guys get an exam question on a C exam or on a certification exam, and they tell you, well, which agent will get into the blood-brain barrier, the first thing you got to look for is see if it has a charge. If it's uncharged, it's going to get in. Okay? As soon as you charge the molecule, it's not going to get in because it becomes ionized. Okay? Make sure, somebody told me to tell you guys, was one of the students that's now graduating, or just graduated, said that in the question that they asked in the test was they asked, instead of using unionized, they used the word neutral, which is something we don't use in the school. We tend to tell you it's either ionized or unionized. The way they're putting in the actual questions, they're actually saying it is neutral, which is fine. We'll just use another word. Okay? But neutral means it has no charge. Okay? Atropine and scopolamine are, as a consequence, tertiary means and are able to penetrate the blood-brain barrier, and that's what limits their usage. Okay? That's what makes them poisons. The quaternary ammonium, on the other hand, is ionized, okay, which is an ammonium that has 4 different bonds to it. As a consequence, it becomes a positively charged molecule and is less likely to penetrate the blood-brain barrier. Listen to me very carefully. Less likely. Does that mean that it never enters into the blood-brain barrier? It just means that it's less likely. So if you have somebody who is appearing to have central cholinergic crisis that has not received atropine, scopolamine, but did reverse them with the glycopyrrolate, you can still assume that the glycopyrrolate had gotten across. You know, and I wish somebody had told me that, because when everybody first taught me this, it was said as absolute. It's not an absolute. If you give enough glycopyrrolate to somebody, it will cross the blood-brain barrier. It's just the chances of it are lower. The reason it crosses the blood-brain barrier in some people is because they're older, their blood-brain barrier is not as intact, okay? Or they may have some kind of problem, like had a stroke in the past, and the blood-brain barrier in that area of the brain is not functional. So in that situation, glyco will penetrate, okay? So be careful with absolutes in medicines. There's not always an absolute. So where is the muscarinic receptors at? And what I'm finally sort of coming up with a conclusion, which I keep saying all the time, is that the first receptor that comes out of the spinal cord is always an acetylcholine receptor. Okay? And always it's a nicotinic receptor, it seems like. Okay? That includes the ones in the muscle. It also includes the ones that are preganglionic for sympathetic as well as parasympathetic. So they're all nicotinic. Where the muscarinic receptor is at, which is where the anticholinergic is working at, is in the postganglionic receptor. Okay? Now, let's make it even more complicated than that, right? So now you know that the muscarinic receptor you're binding to is at the postganglionic, okay? But the mechanism is basically the anticholinergics combined reversibly with the muscarinic receptor and thus prevent access to acetylcholine to that receptor site. So basically it's an antagonist. It does not result in cell membrane changes and associated inhibition of the adenyl cyclase, because remember, this muscarinic receptor doesn't release sodium or anything like that. It's a G-coupled protein which is causing, in this case, adenyl cyclase to be released, and it increases calcium permeability. There's actually 5 distinct muscarinic cholinergic receptors that have been cloned, and that's what we know so far. Okay? These receptors are found in the heart, lungs, stomach, CNS, airway, smooth muscle, and glandular tissue, and they actually have different abilities. Well, that's kind of good, because if you have one muscarinic receptor site, say in the heart, and you can figure out what's different about it, you can actually make a medication that hopefully in the future will only bind to that muscarinic site, and it will avoid the other ones. Okay, so you're looking for specificity. Right now, the medication that we're using, which is atropine, glycopyrrolate, and scopolamine, tends to be not as specific. Okay, it seems to bind to different sites, and that's why the drugs, even though they're anticholinergics, they work differently, as we'll show you in a minute. So the muscarinic receptors, you have M1 through M5. The M1 is central nervous system, as well as M4 and M5. So those are the ones you would try to avoid, because those are the ones that have the more of a bad effects, so all cause sensorium changes. But M2 is, would be a one that you'd want to use to increase heart rate by inhibiting the parasympathetics. And M3 may not be one you might want to use because it has airway smooth muscle and salivary glands, which causes increases in salivation. M2 activation, if you were to activate it, causes bradycardia. Okay, but when you're giving this anticholinesterases, you will normally see an elevation in heart rate. Okay, so these are the clinical effects of direct binding, not of the antagonism, which is the anticholinergics do. Okay. The acetylcholine receptors can be broken down into the muscarinic and nicotinic receptors. This is more for review to help you with your testing. The muscarinic receptors are parasympathetic postganglionic receptors. Normally, they are binding sites for acetylcholine, but they also are the binding sites for the anticholinergics. So that's where the anticholinergics bind. The sympathetic preganglionic sites are normally nicotinic, but they're finding recently that they're also muscarinic sites as well. So remember, we keep having this discussion back and forth. Depends on who you're reading and who's doing the research. Some researchers are finding out that there is muscarinic sites in the preganglionic sympathetics. And that's important because ketamine binds there, okay, and causes the effect of the ketamine effect, which causes sympathetic stimulation. Okay, it's actually an agonist-like activity. Okay? So if you look at the actual receptors, the way they actually look, okay, there's variability in the sense of these are the nicotinic receptors. You actually have different different combinations of proteins here, and that combination makes the sensitivity to neuromuscular blockers to be specific to the neuromuscular junction. Okay, if you look at the nicotinic receptor sites, the neuromuscular junction has a 2 alpha, 1 beta, and 1 gamma site, so it's a 2-1-1-1 ratio. It's binding sites for the acetylcholine and neuromuscular binding sites, which is really kind of good because if we didn't have specificity like that, we'd be binding all the other nicotinic receptors, which would be really bad. Okay? So the neuromuscular blockers don't do that. Okay? The reason they don't bind to them is because the parasympathetics and sympathetic preganglionic sites are differently configured. Okay? They have not this 2-1-1-1 ratio. You also have neuronal types. There's basically 12 different nicotinic receptor subunits that have been found. Okay, although alpha 2 to alpha 10, and then you got beta 2 through beta 4, and you got all sorts of crazy combinations. And this actually, there's differences in animals. Okay, what's really unique is that almost every neuromuscular site, nicotinic site, has the same alpha 1 times 2 with beta, gamma, delta. Okay, so it has that same configuration everywhere you go. So if you shoot a monkey with a neuromuscular dart, he comes off the tree dead. Okay? If you shoot an animal like an elephant, same thing happens. So it doesn't matter which animal you shoot with a non-depolarizing agent, it will work. Okay? But if you give different kinds of agents that you expect neuronally to affect, you will have different differences in animal species. What we're looking at here, this is just a review again of the parasympathetic and sympathetic system. The parasympathetics, of course, are taking the first receptor going out far. So these are the nicotinic receptors here, okay? And then your postganglionics, which is the ones that show the muscarinic sites, are the ones in the heart and the other salivary tissues and sweat glands. Okay. States of associated autonomic dysfunction, which is sometimes going to be a problem in the sense of reversal, okay, will be different diseases like this, which will affect how the neuromuscular junction, the actual muscarinic site is going to be affected. So just be careful with these. People are more sensitive to these medications. Now, sensitivity of different receptor types. Lower doses tend to inhibit the muscarinic cholinergic receptors that control salivation and bronchial secretions. So when you give glycopyrrolate, robenol, and scopolamine, all of them are going to have greater salivary effects than they're going to affect on the heart. They tend to be more sensitive. Larger doses will then hit the heart and the eyes. And even larger doses will then be necessary to affect the GI and the genitourinary tract. Which means that if you want to give a drug that's an anticholinergic and you want to work on the GI and the GU system, you're going to have the problem with the heart rate increases. And that can be a detrimental thing. And the highest doses, which was at one time we thought we were going to be able to treat this, was to decrease gastric acid secretion. And imagine giving large doses of atropine where now the person's pupils are dilated, they're kind of whacked out, and they're they have no gastric acid secretion, so they're not getting peptic ulcer disease, but they're kind of weird otherwise. That didn't really work. So that's why these medications weren't really useful clinically in that respect. So you can see from least sensitive to the most sensitive to most difficult to block is gastric secretion. The most sensitive to block is salivary glands. So comparative studies have been done with these medications. These are all anticholinergics, which is atropine, scopolamine, and glycopyrrolate. So how do you look at this? Well, atropine and scopolamine both penetrate the blood-brain barrier, but glycopyrrolate doesn't, or not as much. So if you're looking at sedation, glycopyrrolate is going to have the least effect. Scopolamine tends to be much more lipid-soluble, so because of that, it has much greater sedation than atropine. Okay, so scopolamine is a great sedative agent, and actually is used in trauma extensively. If you have someone with no blood pressure and you want to scramble their brain, and you don't really have a lot of ketamine around, we use scopolamine. Okay, scopolamine is at 0.4 milligrams IV, you're gone. Okay, and they will be gone for 8 to 12 hours, so it's not going to be a short duration of action. As for anti-sialog, which means a decrease in salivation, scopolamine is pretty potent. Actually, glycopyrrolate is a little bit more potent than atropine. The heart rate is the most potent in the sense of onset time. It's atropine, but if you look at the heart rate increases, if you were dose equivalent, atropine and glycopyrrolate are almost the same. If you look at it's a sense of mydriasis, which is eyes, you get more effects with scopolamine because it penetrates into the eye better. And prevention-induced nausea, motion-induced nausea is better with scopolamine. Okay. So the difference in potency between drugs, scopolamine tends to be a greater anti-sialog and has greater ocular effects compared with atropine or glycopyrrolate. Scopolamine is basically about 3 times more potent than atropine as an anti-sialog, and glycopyrrolate is approximately twice as potent as atropine as an anti-sialog. So if you have a choice for drying somebody up, it's not really a good choice as atropine. It's really glycopyrrolate if you don't want any kind of CNS effects. Scopolamine has a big downside that it has increases CNS potency, much more so than atropine or glycopyrrolate. If you look at scopolamine, it's 100 times more potent than atropine in its sedative effects. Now, that's something that's bad in the elderly. Okay, if you have somebody who's really old, scopolamine is already going to be a pretty good sedative. So if you get too much more, then they go into the toxicity range, which is the central anticholinergic syndrome, which we'll talk about in a little bit. Scopolamine also is used to enhance the sedative effects of opiates and benzodiazepines. It causes very intense amnesia. So does atropine, though less. And the other thing you see is CNS effects ranging from restlessness to somnolence, especially in the elderly, which means that you're more likely moving towards the overdosage or the central anticholinergic syndrome. Glycopyrrolate has no central effects unless the person has something wrong with their brain, where their blood-brain barrier is abnormal. But sometimes you'll see that, and you can't really put your finger on it, why the guy's acting so strange, and why is this just not the way it should be. And all at that point you got to do is just reverse that effect, and we'll talk about that in a minute. And atropine has greater potency at the heart, bronchial smooth muscle, GI tract, and scopolamine. The pharmacokinetics of these drugs is they're very poorly orally absorbed. Okay? In the old days, the very beautiful plant called belladonna, okay, was used by women extensively in the Mediterranean. And what they would do is they would crush the plant up, and then they would put it in their eyes. The reason they were putting it in their eyes is it would give them a dilated pupil. The reason that is it's sexually attractive for the male, so it was used extensively during the Greek phase as well as during the Roman phase. The problem with it is it made people crazy. Okay? If you put enough belladonna, which is atropine and scopolamine, into you, and you absorb it, you start acting completely insane. Okay? Which is what they call hysterical. Okay? That's where the word hysteria came from. It's from the overusage of this medication. Scopolamine's duration of action, if you look at the duration of onset for atropine, it's very, very fast. It's usually expected to hit in about 1 minute. Okay, so it's basically one heart circulation. The duration is about 30-60 minutes. Okay. As for scopolamine, the onset is rapid if given IV. If you give it transdermal, it could take 2 to 3 hours before it kicks in, and it could be as long as 4 hours. The duration of action, though, is very long with scopolamine. Once you do give it, you're looking at 60 to 90 minutes. Glycopyrrolate, on the other hand, the onset time is a little slower. It takes 2 to 3 minutes to kick in. So if you have somebody with severe bradycardia that's very symptomatic, the first anticholinergic you pull out is atropine. Glycopyrrolate is pulled secondary. We tend to pull glycopyrrolate if it's something controlled because we don't want to get the blood barrier effects. So we tend to give that drug instead if we have time. The duration of action is almost the same as atropine. So this is what belladonna looks like. Okay, it actually comes in as a fruit. Okay, and people used to peel it off and then eat it, and you would die. Okay, so not something you want to see. Anything that has, I don't know, if you go into nature and you start seeing the blackberries around, watch the animals. If you see the bears sniff it by or the other animals like monkeys don't touch it, you shouldn't touch it. Okay, pretty much anything a monkey can eat, you can eat. Okay, that's one of the things they used to teach us when we were in survival training. Okay, so you watch something that's very similar to you in what they're eating, and you can pretty much eat that stuff. If you see the monkey eat it and they go kind of crazy, which is what they'll do, okay, that's really something you should avoid. Okay, it's a lot of times what the humans did was they watched what animals were doing. But this is what they actually would take and crush up, and then they would put this in their eyes. Okay, so this is the belladonna plant. Actually, not ugly looking plant. It's kind of looking a blackberry, kind of funny looking. Okay, it's something that would make me cautious because anything that looks spinous like this, or star shaped, I'm always worried about. It tends to be poisonous. Anyways, atropine and scopolamine are both tertiary amines. Glycopyrrolate, on the other hand, is a quaternary ammonium, so they have minimal blood-brain barrier penetration. As for metabolism and elimination, that's part of the pharmacokinetics. Atropine is extensively hydrolyzed in the liver. Intratropine and tropic acid is a minimal amount metabolized in the plasma. So it takes a little bit of time for this to get rid of. So elimination, half-life, looking at about 2.3 hours. And about 18% of the stuff is unchanged in the urine. Scopolamine, which is very lipid-soluble, has to be broken down by the liver more, okay, which is almost entirely metabolized, and about 1% is left unchanged in the urine. So that's where the issue becomes. Glycopyrrolate, on the other hand, is water-soluble. So what do you expect what major organ get rid of glycopyrrolate? The kidney, okay, which it is. 80% is excreted unchanged in the urine. So glycopyrrolate is easily removed by the kidney because of its water solubility. It does get hydroxylated and oxidated in the liver, but that's very limited. It's about 20% of it. And elimination half time is much faster than atropine, which is about 1.25 hours. The problem where you'd be is a patient that has renal failure. If you give them glycopyrrolate, it would stay on board for a long period of time. Okay? So be careful with uremic patients and giving them glycopyrrolate. Anticholinergic clinical uses are the following. Okay? You can have preoperative premedications, sedation. You can use it as an anti-sialog. We use that so when we're doing fiber optic bronchoscopy to dry somebody up. Treatment of reflex-mediated bradycardia, combination with anticholinergic drugs, which we just talked about. Bronchodilation for biliary and uteral smooth muscle relaxation. That's usually more rarely because you get that effect only after the heart rate effects, which can be detrimental at times. Mydriasis and cyclopegia may also occur, which I'll show you pictures of that. It will antagonize gastric hydrogen ion secretion. Again, it's hardly used because it's really a very high dose that requires that. Where we use it a lot is for prevention of motion-induced nausea. Scopolamine is the agent of choice for that. And it's a constituent of a lot of non-prescribed cold remedies. And I'm not going to talk really about Parkinson's disease, but it's in the other course in treatment of hiccups. Personally, I've seen it work in hiccups. When you have an LMA and you get somebody who develops hiccups, you get 0.4 of glycopyrrolate and the hiccups go away. Okay? So it's inhibiting the vagal reaction. Preoperative medication, the reason we do it is to prevent vagal-induced bradycardia. This used to be extensively used in the 1970s and 1960s when we were premedicating everybody with IM morphine. So usually they would combine IM morphine with IM atropine. Okay? Atropine would give you some form of sedation, and it would maintain the heart rate without causing the bradycardia that morphine would do. The anti-sialog properties were used extensively in those days because people were using more inhalational agents for inductions. So they didn't want saliva going all over the place and all over their mask. Okay, so in certain populations, they're much more sensitive to producing high doses of saliva. So giving them an anti-sialog is a little bit more comfortable for you. It makes them pretty uncomfortable because most people are miserable that they have dry mouth. Okay, and it also has a sedative effect. For sedation, the best choice is scopolamine. It's 100 times more effective than atropine and enhances the effects of opiates and benzodiazepines. Usually what you do is you give scopolamine at 0.3 to 0.5 milligrams IM in an adult. In a trauma patient, you would give it IV. I don't recommend that IV because it's too potent. It penetrates the blood-brain barrier very rapidly and scrambles people's brains for prolonged periods of time. The anti-sialog effect, scopolamine is greater than glycopyrrolate and it's greater than atropine. Scopolamine is approximately 3 times more potent than atropine, and glycopyrrolate is about 2 times more potent than atropine. Glycopyrrolate is used as an anti-sialog effect without sedation, so that's why I use it. If I'm trying to drive somebody up to do a fiber optic bronchoscope, I usually use glycopyrrolate and avoid scopolamine because it's too much sedation. An equivalent dose of scopolamine is less likely to produce heart rate changes in comparison to atropine. Okay, so you're looking at 0.3 to 5.5 milligrams IM, scopolamine 2.4 to 0.6 milligrams of IM atropine. You get more sedation with that and with less tachycardia. The reflex-mediated bradycardia, the most rapid onset, the most appropriate drug for somebody who's severe bradycardia is atropine. You give it 15 to 70 micrograms per kilo, which you're looking at least is 0.4 milligrams to 0.6 milligrams IV. And the bad side to it is it causes a central cholinergic crisis, possibly. The slower and onset glycopyrrolate takes 2 to 3 minutes to take place. The benefit it does not cause a blood-brain barrier. So you have somebody who's not unstable, then maybe glycopyrrolate is a better choice. The effects on heart rate overall, if you dose equivalently, atropine and glycopyrrolate really no different. Okay, you do see scopolamine have a lot less of an effect on heart rate than those other agents. Most effective in young adults compared to infants and elderly. And volatile anesthetics may actually decrease the dose of anticholinergic required to increase the heart rate. The combination with anticholinesterase drugs, of course, we talked about this before. The anticholinesterase cause a rapid increase in acetylcholine at the muscarinic sites, leading to a severe bradycardia and asystole. So to prevent this, the anticholinergic agents are used to have the same onset time. So atropine and idurfonium are the ones that put together, and neostigmine and glycopyrrolate should be put together. Glycopyrrolate may be the preferable in patients at risk for cardiovascular complications due to shorter duration of action, okay, because of its metabolism. Okay, these are the 2 pictures of glycopyrrolate and atropine. Okay. Bronchodilation is the next thing. Is another reason to use anticholinergics. What they do is they relax bronchial smooth muscle. They decrease in airway resistance can occur, and an increase in dead space in patients with asthma and chronic bronchitis. The anticholinergics are more effective when given as an aerosol and have less cardiac side effects. They used to give atropine a lot in the days, but atropine still causes a lot of increases in heart rate. So they came up with a new drug, which I'll show you in a minute. Glycopyrrolate is equally as effective as scopolamine and atropine without the CNS effects, and may cause inspissation of the secretions, which may lead to airway obstruction, which may be a real problem when using these agents. It dries out the actual mucus and makes it become like concrete, and these people can then have what's called inspissated secretions, and it's very, very difficult to pull this stuff out unless you go in there directly with a fiber optic scope. Ipratropium, which is called Atrovent, which is I use quite a bit. I combine it almost always. Every time that I give somebody albuterol, I give ipratropium bromide with it. The reason I do it is it dries out the secretions a little bit, and it helps patients that have bad COPD and history of bronchitis. Patients with asthma may not necessarily be as good, but it's an N-isopropyl derivative of atropine. It's a quaternary compound, so it doesn't cross the central nervous system. And it's available as either a meter-dose inhaler or as a nebulizer solution. I tend to use a nebulizer solution. It's more effective in preventing in treating bronchial asthma due to beta blockers or psychogenic stimuli. And the bronchial asthma and ipratropium has a little slower onset. Duration takes 4 to 6 hours. But it's a little bit less effective than the beta agonist. That's why I use ipratropium with my other agent, which is albuterol, which is a beta agonist. Ipratropium may be more effective in chronic bronchitis or emphysema with beta agonist drugs due to the drying effect. This is what ipratropium comes like. This is the meter-dose inhaler in the bottom, and this is the actual nebulized form. You just put the liquid into the nebulizer, and the person inhales it. That's what I tend to use as my unit dose. It may prevent bronchospasm due to intubation response. That's why I use it. Okay, I think it makes a big difference, especially if somebody has a history of high bronchoconstriction and a history of asthmatic component. Then I add the ipratropium for that reason, because we're going to go intubate this patient in a minute. Effects on heart rate and intraocular pressure do not occur with ipratropium compared to atropine, which makes it, I think, much better agent to use. And it has minimal systemic absorption because of the quaternary ammonium, so it tends to stick to the lung, not really go into the brain and go anywhere else. If you look at biliary and ureteral smooth muscle relaxation, this is very ineffective if you're giving it IV. I don't recommend doing it for that reason. Okay, but one of the things that you can have after surgery, like a prostatic TERP syndrome, or where they actually put in a Foley catheter in somebody and still them, is you can use an anticholinergic, but we use is a B&O suppository. I'll show you what that means. B&O suppository is belladonna and opium. Okay, belladonna is that flower that I just showed you. That flower has about 20 different alkaloids, which it has morphine, papaverine, and codeine in it. It also contains within it also atropine and scopolamine in different concentrations. So that's the belladonna component. The opium itself has the 20 alkaloids. So the belladonna itself will give you the anticholinergic effect, okay, which prevents spasms of the ureter, and it's thought to also decrease the tone of the bladder and sphincter, and it's supposed to decrease that effect so you don't get that urinary retention as well. The way these are instilled is of course, a suppository rectally, and it usually works really, really quickly, and it makes a huge difference in patients' comfort levels. And sometimes you're fighting it by giving narcotics, and that's really not going to help you until you use this device. Okay? Just think about that, because you will encounter this problem when you get to clinical. The next one is mydriasis and cyclopegia. Mydriasis means that the pupil is going to dilate. The anticholinergics placed topically on the cornea result in mydriasis. And cyclopegia, which means an inability to accommodate. Okay? The atropine, then you give it to somebody who's in the cornea, on the eye, it takes almost 7 to 14 days to recover. So you're looking at a long period of time. So this is one of the agents where you do not want to give it to a patient who has glaucoma, because when you relax the ciliary muscle, may actually occlude the angular space, which is here. Okay, the angular space is right here. This is where the actual intraocular fluid is being produced or drained, and if you occlude that, then the intraocular pressure increases and make the glaucoma worse. Patients with glaucoma should also not be given scopolamine, and that's a big concern. If you have people that are going on a trip, okay, that are going on a boating trip, what's the first thing that most people put on themselves? They put scopolamine. One of the things you should always ask is, do you have glaucoma? If you have a patient coming to your outpatient center and you're trying to prevent nausea, vomiting, then you also got to ask them, do you have any glaucoma? If you do have it, then scopolamine is contraindicated, and you should stay away from it. Okay? Glycopyrrolate has the least effect on pupil size of all the anticholinergics because it doesn't penetrate into the eye. Now, I had a case a few years ago where a patient had just put on them scopolamine. And about an hour later, the nurses were all freaking out and said, the patient's herniating. So I, what do you mean, the patient's herniating? Well, the pupil's blown. So I walked over and looked at the woman's eyes, and one eye was completely, mydriatic, and the other side was normal. And I said, okay, ma'am, how did you put the scopolamine patch on? The nurses are listening in. They go, well, I put it in my hand, and then I put it in my back here. I said, did you wash your hands afterwards? I said, no. Did you scratch your eyes after you put that patch on? I said, yeah, I was itchy after the Versed. Okay, so what happened was she took the scopolamine, put it in her face, scratching her eye, and put it into her eye. Okay, and the scopolamine affected that one eyelid. So when you say what's called anhidrosis, which means you get only one eye gets pupillary vasodilated, okay, that's what the effect is, usually because of contamination of the eye. Okay. IV administration of atropine or glycopyrrolate to treat bradycardia does not produce sufficient tissue levels of increased intraocular pressure unless you get into the toxic range, so it's something you don't have to normally worry about. It's usually scopolamine. So scopolamine is really the agent of choice for motion sickness. Its transdermal absorption provides really sustained plasma concentrations. And the way you put it is post-auricular, usually lasts for 72 hours, but it's best applied to 4 hours prior to stimulation. You can show us you here how the wafer is set up. You have the impermeable back layer with the protective peel strip. If you put your finger on that, you will get scopolamine on your fingers, and you will contaminate yourself if you're not careful. You should wash your hands after you put the scope derm patch on. Nothing worse than destroying your vacation when you have one eye that's dilated and you can't see when you go out in the sun. Okay, you tend to go around in circles with your right. Okay, so it depends on which side you put it on, of course. Okay, so anyways. Scopolamine is effective in treatment of nausea or vomiting associated with morphine, PCA, or epidurals, which is kind of nice. It's effective in preventing nausea and vomiting, especially for middle ear surgery, which is a high risk. And prophylactic transdermal scopolamine the evening prior to surgery decreases nausea, so with laparoscopic using general anesthesia. It doesn't eliminate it, but it decreases the incidence. Okay? All this stuff doesn't work. Okay? This is what the scopolamine risks are. This is what I was talking about before, about anisocoria. This is the person has a dilated pupil on one side. The way they did this was a scopolamine patch was applied on the same side, and they got it. And when you give this person topical pilocarpine, they don't respond to it. Okay, that would decrease the size, but with the scopolamine, you don't get reversal. You also can see what scopolamine causes hyperpyrexia, especially in kids. They tend to be more sensitive to increases in body temperature. And the other bigger risk is you get into higher doses, you get into a central anticholinergic crisis and overdose. So what are the drugs that can cause central anticholinergic syndromes? You have the antihistamines, the antidepressants, the antipsychotics, belladonna, which is atropine, the alkaloids like scopolamine. All these different agents can cause the central anticholinergic syndrome. Now, the most common things that you see if you develop an overdosage and it gets into the blood-brain barrier and you get what's called the central anticholinergic syndrome is you get agitation. The patient's fighting you. The patient can't really tell you where they're at. They seem to be out of it. They can have ataxia. They had confusion, somnolence, and they can go into a coma and go into a respiratory arrest from it. They will usually have hallucinations, will be kind of apprehensive, and be delirious and paranoid. So they're acting totally crazy. They have emotional instability. Their muscles are incoordinated and weak. Okay? They're always associated with nausea, vomiting, which is interesting. You're preventing nausea and vomiting, but when you get into the higher dosages, you're causing nausea and vomiting. You also can cause fever. Okay? Atropine fever is something you should all know about. One of the things that we do when you see a code and when you're given a milligram of atropine, almost everybody gets a fever afterwards, and that's from the atropine is getting anticholinergic effects that the person's still unconscious. You don't realize that they have central anticholinergic crisis. You'll see opisthotonus, torticollis, and you get depression of stimulation or sometimes a little bit of stimulation. So pretty serious complications of this, to say the least. What you see in the elderly patients may be really much more sensitive to this, and the inhaled anesthetics actually potentiate these effects. Okay? How do you treat this? And the answer is you give physostigmine. Physostigmine is a tertiary anticholinesterase that is able to penetrate into the blood-brain barrier and reverse this effect. Of course, if you give this, you increase the risk of nausea and vomiting as well. It's effective in reversing this CNS effects, and glycopyrrolate may still cause CAS, although rare, which is the central anticholinergic syndrome. So physostigmine still is an appropriate drug of choice. Where did physostigmine come from? It came from Africa. Okay? The original place where it comes from is called the Calabar bean. Okay? The Calabar bean is actually found, I think, in Kenya. The initial way they described it was the population would take these Calabar beans as a form of knowing if you were guilty or not of a crime. If you were guilty of a crime, they would make you eat the Calabar beans. If you survived it, you were not guilty. If you died of it, you were guilty. Okay? And what physostigmine basically does is that if you give it in too high doses, it'll do you in. So not something you want to give too much of. Usually 0.4 milligrams per kilogram is adequate for treatment and reversal effect. Now, what happens if you overdose somebody on anticholinergics? You do get rapid onset of symptoms. The symptoms are dry mouth, swallowing is difficult, vision is blurred, photophobia, tachycardia, skin is dry. You get hyperpyrexia, and you get increased respiratory rate, increase in dead space. And if you continue getting it into the toxicity range, it'll form coma and medullary ventilatory center paralysis. These overdoses are still treated with physostigmine, and it will reverse it very quickly. And the last slide is the effects of anticholinergics on the decreased barrier pressure, which is the esophageal tone. They define as gastric pressure minus esophageal sphincter pressure. And what atropine and glycopyrrolate do is they decrease the lower esophageal sphincter pressure and thereby decrease the barrier pressure and make an increased risk of developing aspiration of this individual. Okay, so sometimes when you reverse somebody and you give them glycopyrrolate and reversal, you see that they vomit more because this lower esophageal sphincter is actually relaxed more. Okay? Okay, that's it.